Hello everyone, I hope and I believe you all are doing great. This is Dr. Arya, your pathology faculty. Now we will be starting with the endocrine system. Now we will be starting with our endocrine system, okay? And endocrine system will be divided part wise, okay? So this is the part 1, because if we will study it part wise, then it will be very easier for you to revise at the end, okay? Let's just start. So first thing we have is about the anterior pituitary tumors. So anterior pituitary tumors are basically the pituitary tumors which are more common in the intracranial neoplasms, okay? Intracranial neoplasms. They are usually benign type. They are usually benign type and arises from something called as a adenohypophyseal cells. Adenohypophyseal cells, okay? See this figure. Over here, you have your pituitary gland, right? Then you have the anterior lobe and then you have the posterior lobe. Pituitary is almost divided into the two lobes, anterior lobe and the posterior lobe, right? If I talk about the epidemiology, then it accounts for almost 10 to 15% of the intracranial tumors, most common in people who are at the age of 30 to 60 years. Okay, and male to female incidence is almost equal. Okay, it is not biased towards a particular gender. All the genders have equal predominance, all the genders have the equal epidemiology, right? Next thing you have is let's see about the normal pituitary anatomy. So I have already told you that your pituitary gland is divided into two types. What are the two types? You have the anterior pituitary and you have the posterior pituitary, right? You have the posterior pituitary. Now, this anterior pituitary is called as the adenohypophysis lobe. Adenohypophysis lobe. Because adenohypophysis A and anterior. A for A. Then this posterior pituitary is also called as your neurohypophysis. It is also called as your neurohypophysis. Okay, these are the two things which you need to keep in mind. Let's see about the cell types of the anterior pituitary. So the main cell types you have is the first one is your growth hormone, right, which is essential for the development of your body, right, for your height and for everything. Then you have the prolactin, then you have the ACTH, then you have the TSH, that is your thyroid stimulating hormone. Then you have the LH and FSH, okay. These are nothing but your gonadotrophs. Let's just revise what are the things we have. We have the somatotrophs, that are your GH, growth hormones. Then you have the lactotrophs for PRL, that is your prolactin hormones. Then corticotrophs for ACTH, thyrotrophs for TSH, and gonadotrophs for LSH, FSH, and LH, okay. Then you have the classification of adenomas. Let's see how they are classified. So if I talk about the classification, the first thing, either it can be depending on the function. So on the function, either it is functional or either it is non-functional, right? Then next is based on their size. If it is less than 1 centimeter, it is your microadenoma. And if it is more than 1 centimeter, it is your macroadenoma. So this thing you need to keep in mind. See, since the festival of light, Diwali, is nearby, so there are two type of people. First one, who will be in full enthusiasm to do all the Diwali work, to do all the chores that the mother has given to them. Second one are my type, who are lazy and they are not willing to do any kind of work. Okay, so you should not be the second one, you should always be the first one, although I am the second one. So either it can be functional or it can be non-functional. If I talk about the pathogenesis or overview, then you have what? Then you have there is a monoclonal proliferation. Okay, there is a proliferation of cells. Okay, what are the cells of anterior pituitary you have? You have your adenohypophyseal cells. So there is a proliferation of them. After that, what happens is there is genetic and molecular abnormalities. Okay, we will see. There are genetics and molecular abnormalities that will be taking place. We will see them in details. Okay. If I talk about the molecular pathogenesis, then in the molecular pathogenesis, what you need to keep in mind is you have something called as your GNAS mutation. Okay, there is GNAS mutation. After that, what happens is this GNAS mutation activates your 𝗶𝗵𝗵, that is responsible for the activation of your 𝗶𝗵𝗵. Then what happens is there is mutation in MEN1. MEN1 gene mutation is there. Okay, you have the syndromes MEN1 and MEN2, A and B. Okay, for MEN1 you have 3Ps, right? We will study them in details. Don't worry, just remember that this is basically a mnemonic. Okay, in MEN2 it is A and B, so in MEN2A you have the 2P's and in MEN2B you have 1P. Okay, this is a journal mnemonic. We will study in detail. Okay, don't worry. What is the role of 𝗖𝗵𝗵 pathway? So 𝗖𝗵𝗵 pathway, what it do is there is a increase GS alpha mutation. Basically what it do is it increases the level of 𝗖𝗵𝗵. It increases the level of 𝗖𝗵𝗵 and promotes the uncontrolled cell proliferation Next, we were talking about the MEN syndrome. So first one we have is the MEN1 syndrome. So MEN1 syndrome, what happens is there is germline MEN1 mutation, which leads to the development of 3 tumors. I have told you that there will be 3 P's. What are the 3 P's? Here, the 3 P's will be, there will be the tumor of what? Tumors of your pituitary, then tumor of your pancreas, then tumor of your parathyroid, then tumor of your parathyroid. There will be 3 P's that will be involved. Okay, you need to keep this in mind. Now let's look at a hormone producing tumors. So first thing, you have the prolactinomas. They are the most common. Okay, prolactinomas are the most common one. Then you have the growth hormone adenomas. See, whenever you are encountering the term of adenoma, okay, so always think that you are dealing with something called as tumors. Pituitary adenomas means adenoma of the pituitary gland. You are dealing with the tumors of the pituitary gland. Okay, this thing you need to keep in mind. Next is you have the growth hormones adenomas. Okay, then corticotrophs adenoma and gonadotrophs and thyrotrophs adenomas. They are rare. Okay, first one, let's see about the prolactinoma. Okay, prolactinoma. Lactinoma is suggesting it is related something to your lactation. Okay, it is related something to the lactation. So it is the most common functional pituitary tumor. The prerequisite for this kind of tumor is that your pituitary gland should be functional. What are the causes? So the causes can be, there can be hyperthyroidism. prolactinemia, and there can be second thing hypogonadism. Okay, hypogonadism. These two things can occur. What are the clinical features? First, there will be galactorrhea, amenorrhea. What is amenorrhea? Amenorrhea means absence. A means absence. Absence of what? Absence of menses. Absence of menses. Okay. Then there will be infertility in females. Decreased libido and impotence in males. Libido means the sexual desire. There will be decrease in the sexual desire. Okay, there will be decrease in the sexual desire. Now, if I talk about the morphology, see, this particular thing that I am highlighting with red is nothing but the tumor, the prolactinoma that you will be encountering. So, as you are able to see in the figure, it is soft, it is well circumscribed lesions, and it may compress your optic chiasma. Okay, it may compress your optic chiasma. And if this compresses your optic chiasma, then there will be visual defect also. There will be visual defect. Okay, this you need to keep in mind, right? Next you have is the GH secreting adenoma. The causes are, this thing you need to keep in mind. If I told you that there is a GH secreting tumors, then in adults and in children's, they both are different. In adults, you will be having something called as your acromegaly, and in children's, you will be calling it as gigantism. Gigantism. Okay. So remember A for A. You remember the example of great khali. Okay. Okay. Next, if I talk about the pathogenesis, then what happens is, first thing, what is there? There is GNAS mutation. After that, what happens is there is increase in the growth hormone, then there is increase in the IGF-1, and then there is tissue overgrowth. There is tissue overgrowth. This thing you need to keep in mind while answering the question. Okay. So, see this diagram. What you are having is, in acromegaly, there is excessive growth hormone secretions. Then there is prominent chin and jaw. If you have ever seen the picture of great khali, then you know that the chins of that persons are very prominent, and they are very sharp also. Okay, and they are having a large hand. See, I have a very small hand, right? Similarly, those who are having this kind of adenoma, those who are having this kind of tumors, their hands are very prominent. Okay. If I talk about the clinical features, there will be enlarged of hands, feet and jaw. Okay, hand, feet and jaw will be enlarged. There will be diabetes mellitus. Okay, why? Why there is diabetes mellitus? There is diabetes mellitus because in patients of acromegaly, there is insulin resistance. Okay, there is insulin resistance. And guys, whenever we are encountering the topic of diabetes mellitus, you are the one who will be telling me about the criteria of diabetes mellitus. Okay, criteria of diabetes mellitus. Next, if I talk about the morphology, then you have the acidophilic cells with densely granulated cytoplasm. See, this very beautiful picture that you are able to see, the large infiltrates macroadenomas, they are most common. If I talk about the ACTH secreting adenomas, then the most common cause is the Cushing disease. Okay, the most common cause is a Cushing disease. It is derived from the basophilic. It is derived from the basophilic corticotrophs. It is derived from the basophilic corticotrophs. troughs. Okay, this thing you need to keep in mind, that whenever we are talking about the ACTH, one thing that should come to your mind is Cushing disease. Okay, if I talk about the pathogenesis, what happens is there is USP8 mutation which enhances the EGFR signaling, and there is hypersecretion. There is hypersecretion of ACTH. There is hypersecretion of ACTH. This thing you need to keep in mind. Clinical features, there will be central obesity. I'll draw a figure for you also. There is, you know what? There is a lemon on stick appearance. Not like this stick I want to draw. Okay. There is something called as a lemon on stick appearance. Okay. Because you know why it is called as a lemon on stick appearance? Because there is central obesity. Because there is central obesity, the periphery of the person is very, very normal. The only obesity that is there is in the center. There is central obesity. It is the stomach of that person. So there is a central obesity. Okay. Then you are having something called as a moon faces and buffalo hump. Moon face and buffalo hump. Okay. I hope you know how a buffalo hump looks like. Okay, I'm not going to tell you that in details because I know you are living in India. You know how buffalo hump looks. Okay, there will be hypertension and there will be striae. Okay, now I'll tell you what striae is. Like, suppose let's say that this is the stomach of the person who is having a Cushing disease. See how beautiful stomach we have drawn. Okay, so near it, if this is the umbilicus. Now near the umbilicus, I am having some stria. These are nothing but your striae. Blue lines that you will be able to see near the umbilicus. You can say these lines are very, very appreciated when a person is having pregnancy. In pregnancy, these kind of lines are more appreciated. Now, next you have is the gonadotroph adenoma. They are usually non-functioning and presents with mass effect. Okay. Thyrotroph adenoma, they are very rare and cause secondary hyperthyroidism. Let's talk about the non-functional adenomas. So, in the non-functional, as the name is only suggesting, there is no hormonal symptoms. There is no hormonal symptoms. Okay, there is no hormonal symptoms and they may present with mass effect and hypopituitarism. What is the mass effect? There will be headache. The person will be complaining that doctor, I am having a severe headache. There will be visual field effect. In the visual field effect, there will be bitemporal hemianopsia. See, bitemporal means it will be on both the eyes, and hemianopia means it will be on either the nasal side or either the temporal side. You have the two sides, right? You have the two sides, either the nasal side, either the temporal side. So this thing you need to keep in mind. There will be increased intracranial pressure. Next that we will be studying is about the hypopituitarism. What happens is over here is there is compression of normal pituitary tissue which leads to a hormonal deficiency. If I talk about the apoplexy, then in apoplexy there is sudden hemorrhage into the pituitary tumor. See, you are able to see this figure. What is happening in the blood vessels? In the blood vessels, you are able to see that there is a development of the blood clot. And guys, when there will be a development of the blood clot, what will happen? Will the blood be able to reach the brain? Right? No. Then what will happen is there will be necrosis of that area, which will cause acute hypopituitarism and a severe headache to the person. If my brain is not getting proper amount of oxygen, what will happen? I will feel like I'm having a severe kind of headache, right? Similarly, this person also feels the same. If I talk about the gross features, then you are able to see some soft, well circumscribed mass like this. Okay, these are the soft and well circumscribed mass, and they may invade the dura and the sphenoid bones. And I know you know the layers of your skull very well. Okay, layers of your brain, layers of your skulls very well. They have taught you in your anatomy lectures, right? If you're not thorough with the layers, I must suggest you to go to your anatomy lectures and read over there. Okay, if I talk about the microscopy, then they are uniform polygonal cells in sheets or cords. They spare and densely regulated cytoplasm. See, this blue hole are sparely and densely regulated your cytoplasms. If I talk about the immunohistochemistry, then there is hormone specific stains that confirms the diagnosis. Examples are for your PRL, growth hormone, ACTH. They are done. They supports the immunostaining. Okay, then in the electron microscopy, you are able to see what? You are able to see distinct granules morphology, which helps us to identify the types of cell that we are dealing with. In the radiological features, you are able to see that the MRI will show what? It will show the cellular mass. MRI will show the cellular mass, and they may compress your optic chiasma, Okay, what are the differential diagnosis? So in the differential diagnosis, remember about the craniopharyngioma, then you have the 𝗲𝗵𝗵𝗺 meningioma and metastatic carcinoma. These are basically the differential diagnosis which you will be writing in your exams. Complications will be, there will be hypopituitarism, there will be optic nerve compression and pituitary apoplexy. If I tell you about the diagnosis, then it is hormone assay. It is by the hormone assay. You basically have to assess the level of your hormone. Either the level of hormone is increasing, either the level of your hormone is decreasing. So you have to assess that. Then you have to do the MRI of your brain. If I talk about the management, it can be medical, it can be surgical and radiotherapy. So the treatment for prolactinoma is you have to give the dopamine agonist. What are the dopamine agonists available? You have cabergoline, you have bromocriptine. These are basically the first line treatment that which you will be following. Then for the GH adenoma treatment, you will give the transsphenoidal surgery. You will give the transsphenoidal surgery if the jaw is very prominent and if the person is having some difficulty, or they are not, they want it just for the cosmetic repair, then you can give the patient a transsphenoidal surgery. Next, for the ACTH adenoma, either you can go for surgery or radiotherapy, and you can also go for your adrenal enzymes inhibitors. Next, you have the non-functional adenoma treatment. So you have to give the surgery to the patient if they are symptomatic, and regular imaging and follow-up should be there to the patient. Prognosis, this condition is generally benign and recurrence can be there if incomplete excision is there. If you just excise the part incompletely, then there are chances that this problem can again, okay, like if there is a very naughty kid and you just give him 2 to 3 slaps only. I'm not promoting that you should give abuse to the child, but sometimes slap therapy is needed. Okay, so if you just give 2 to 3 slaps to the child and still the child is not behaving properly, right, what you will do, there will be a recurrence. This incidents will happen in the future as well. Child will misbehave in the future as well. So it is very advisable to give a proper treatment to the child. Okay, Then you have the MEN1 associated tumors. They are often multiple and recurrent and requires a long-term monitoring. Pituitary carcinomas, they are rare, very rare, and they are basically defined by the metastasis. Okay, when they not on the histology, when you are able to see that there is a metastasis to one organ to the another, they are metastasizing, then you are able to identify, okay, this is the pituitary carcinoma that I am dealing with. Okay, so this is basically the summary and the key points that you need to keep in mind. See, most of the tumors are of anterior one are basically benign adenomas. Then there can be functional tumors and non-functional ones present late with mass effect. Okay, they present late with the mass effect. Mnemonic that you have is PGA, prolactinoma, GH, adenoma, and ACTH. These are the most common type. So you can remember PGA is the most common type. PGA is the most common type. Histological classification, either it can be densely or sparely granulated variants. Clinical correlations, if I talk about, then you have to check the hormone level and the tumor behavior. These are the two things which you need to keep in mind. This is basically a case study which you will be telling me. There is a 45-year-old female with amenorrhea, galactorrhea. MRI shows pituitary microadenoma. So this is a case of Sheehan syndrome. This is a case of Sheehan syndrome. Okay. So guys, this is the summary table. So you can, this will be very beneficial for you at the end of your exams, right? Just note down the things that you need to keep in mind while writing this answer of anterior pituitary. So the conclusion is that only that you have to do early detection and appropriate therapy to ensure an excellent prognosis. This was all about the anterior tumors. Now we are moving on to the next topic, that is the topic of your hypopituitarism. So if I talk about it, then it is what? There is a deficiency. There is a deficiency. Deficiency of what? Deficiency of one or more anterior pituitary hormones. Okay, there is a deficiency of one or more pituitary hormones, which results in what? Which results from the pituitary or the hypothalamic disorders. So if I talk about the normal pituitary functions, then you have the anterior lobe, and anterior lobe secretes what? It secretes your GH, PRL, SETH, TSH, LH and FSH. They are controlled by a hypothalamic releasing hormones. We all know this. Classification will be, they can be primary, they can be secondary. Primary one is for the pituitary pathology. Primary one basically depends on the pathology, and the secondary one depends on the hypothalamic lesions. And the secondary one depends on the hypothalamic lesions. If I talk about the epidemiology, then it is a rare disorders affecting all the age group. All the age groups are equally affected in this, and we are not biased, so we affect both males and females. We are not just that we will affect females only, we will affect male only. Nothing like that. We will affect both. Okay. It is congenital or acquired. There can be tumor, ischemia, trauma, and infection that can cause it. If I talk about the congenital causes, you have first thing called as your pituitary aplasia. Then there can be genetic defect and there can be Kallmann syndrome, which these are basically the congenital causes. Let's see what Kallmann syndrome is. So Kallmann syndrome, what happens is there is a failure of, you have something called as GnRH neurons. So there is a failure of GnRH neurons, as a result of which what will happen? There will be hypogonadotrophic hypogonadotrophic gonadism. Okay, along with it, there will be anosmia. A means absence. Okay, and nose means nose. Okay, so not the absence of nose, but the absence of smell. Okay, the person will not be able to take appropriate amount of smell. Okay, they are not able to identify that this is the particular thing that I am dealing with. Similarly, if a person is having cough or cold, like me, I am having cold right now, right? So I may not be able to smell the things that accurate. I may not be able to tell you that this is what sweet, this is 𝗲𝗵𝗵𝗺𝗺, this is 𝗲𝗵PH. I'm not able to tell you that. Okay, if you just blindfold me, okay, by seeing I can tell, but if you just blindfold me and ask me on the basis of the smell that I'm getting, then I'm not able to do that. Okay, what are the quiet causes? You have the quiet causes as, remember, SIADH. Remember SIADH. Okay, I know it's just sounding very bad, but remember it as SIADH only. What are the SIADH you have? So you have the Sheehan Syndrome. Then next you have is the, for E, you have the empty cellar syndrome. Then you have the, your P. For P you have the pituitary adenomas, and for another P you have the pituitary apoplexy. Let's see about the Sheehan syndrome. So Sheehan syndrome, what happens is there is postpartum necrosis due to severe hemorrhage. See, whenever they will give you the example, whenever they will give you to diagnose the case of Sheehan syndrome, they will obviously give you that there is a woman who has just delivered a child and the child is just 6 days old or something like that. There will be a history of postpartum. Okay, what happens over here is there is enlarged pituitary which is vulnerable to ischemia. See, over here you are able to see this is the tumor of Sheehan. So Sheehan syndrome, what is there? There is postpartum pituitary gland necrosis. Postpartum means mother who gave birth to the infants. Okay, pituitary glands, glands of the base of the veins, and necrosis means death. See, all the things are there in the name only. You just need to just break down the name. So this disorder is where there is a pituitary gland and they basically occurs to the mother who have just given birth to an infant. Okay, if I talk about the clinical syndromes, so you have a mnemonic, that is 𝗵𝗵. Lactation will be lost, there will be decrease in the prolactin level, there will be amenorrhea, that is decrease in the level of LH and FSH, mixed edema will be there will be pale skin, the skin of the person will be pale. Why it is pale? It is due to that there is deficiency of hemoglobin, there is anemia to the patient, right? Because the patient has lost so much of blood while giving birth to a child. There will be fatigue, there will be adrenal insufficiency and inability to handle the stress and low blood pressure. Next that you have is the pituitary apoplexy. What happens over here is there is acute hemorrhage into the adenoma, there will be headache, visual loss and shock. Next, let's talk about the empty cellar syndrome. There is herniation of subarachnoid space. See, in brain you have some spaces, right? So there is herniation of the subarachnoid space, which are compresses the pituitary glands, and often incidental findings are there. If I talk about the inflammatory causes, there will be lymphocytic hypophysitis. Okay, sarcoidosis can be the causes. There can be TB and fungal infection. In the trauma in surgery, mainly the head injury and the transsphenoidal surgery damaging the pituitary. Maybe the person is undergoing this transsphenoidal surgery and somehow they just damage the pituitary gland, so the person can land up into this syndrome. Okay, there can be radiation injury, like there can be postcranial irritation which is progressive to the pituitary failure. If I talk about the pathogenesis, there is loss of 75% of the pituitary tissue. 75% of the pituitary tissues is lost, which causes the deficiency. The sequences, there will be first GH failure, then FSH and LH level will go down, there will be TSH level will be going down, and ACTH level. If I talk about the molecular basis, then you have the genetic mutations and there is impaired pituitary development. In the morphology, we are able to see some small glands which are fibrotic. Small glands which are fibrotic. Necrosis will be there and hemorrhage will be there depending on the cause. If the cause is trauma, then there will be a lot of hemorrhage that we will be able to see in that particular case. If I talk about the morphology of the Sheehan syndrome, there will be early necrosis. See, N in Sheehan, N represents your necrosis only. There will be necrosis and there will be late fibrosis. If I talk about the apoplexy morphology, there will be hemorrhagic infarction with necrosis and hemosiderin. What is hemosiderin? Hemosiderin is basically a component of iron that you should know. If I talk about the morphology of empty sella, then there are flattened pituitary along the sella force. There will be CSF which replaces the glandular tissue. Clinical features obviously depend on the rate and the number of hormones lost. If the number of hormone lost is more, then there will be more clinical features, and if the number of hormones are lost less, then there will be less clinical features. Growth hormone deficiency in adults and in children. In adults, what happens is, in adults there is a decrease in energy and muscle mass but in children there is dwarfism. Okay. Next, the gonadotroph deficiency. So in women there will be amenorrhea and infertility. In men there will be decreased libido and impotence. What is decreased libido? There is decrease in the sexual desire of the men. And amenorrhea means absence of menstruation. Infertility, you all know, right? If there is TSH deficiency, what are the things we need to keep in mind? There will be secondary hypothyroidism. There will be fatigue. The person will feel lot of lethargy throughout the day without doing even a single work. There will be cold intolerance. Okay, like if the person has said please switch on the AC, after 10 minutes the person will say please switch off the AC. Okay, there will be a lot of cold intolerance. If I talk about the ACTH deficiency, then there is secondary adrenal insufficiency. PRL deficiency, it is due to the postpartum lactation failure. The mother is not able to breastfeed the child properly. Panhypopituitarism, there is a deficiency of all anterior pituitary hormones. Posterior pituitary involvement, they may cause diabetic insipidus. Investigations, you have to check the hormone level, stimulation test and MRI should be done. Basal hormone level, you are able to see that there is decrease in the GH level, ACTH, TSH, FSH and PRL levels. In the dynamic testing, you are able to see there is insulin tolerance test that you will do. You will see the thyroid regulating hormones level, GnRH level, and you will do the stimulation test. Next, in the imaging, the first thing is MRI. So in MRI, you are able to see the cellular atrophy and empty cellular and adenomas. In the autoimmune markers, you are able to see there is anterior pituitary antibodies in the lymphocytic hypophysitis. Differential diagnosis can be, there will be hypothalamic disorders and primary endocrine failure. What are the complications? There will be renal crisis, there will be adrenal crisis, there will be infertility, there will be growth failure. Treatment. When there is growth failure, what I will do? I will give the patient a hormone replacement, and underlying cause of management, like whatever are the underlying things that you are able to appreciate, just treat that. So for the hormone replacement, we follow a particular sequence. What we do is, first we replace corticosteroids. First we replace the corticosteroid. Then we replace the thyroid. After that we replace the sex hormones and then your GH, right? If I talk about the Sheehan management, then you have to give the patient a lifelong hormone replacement, and there should be a stress dose steroid education, because when the mother will take a lot of stress, there are chances that the mother will develop this kind of syndrome, Sheehan syndrome. It's very common, guys. So it is very essential and advisable for you as well to educate the mother properly that don't take stress, everything will be fine. Okay. For the tumor management, what you will do, you will give the patient transsphenoidal surgery and plus or minus radiotherapy depending on the patient. For the prognosis, it is excellent with proper hormone replacement. If there is proper hormone replacement, then the patient will recover for sure. If there is not proper hormone replacement, the patient will take a lot of time to heal. Then you have special syndrome like your Kalman and Propman syndrome. Pediatric hypopituitarism, commonly it is congenital. Congenital means it is present since birth. There is growth hormone failure will be there. If I talk about the histopathology, I am able to see necrosis. I am able to appreciate necrosis. I am able to appreciate fibrosis and lymphocytic infiltration. These all things you have read in your journal path. Okay. Next, if I talk about the endocrine correlations, it must be distinguishing from your primary adenoma and your thyroid failure. What are the key points you need to keep in mind? First thing, there is gradual hormone loss pattern is there, life-threatening adrenal insufficiency if possible. Summary table. Okay, I'm not going to read the summary table because it's for you. So just read the summary table at the end. Conclusion is early recognition and hormone therapy may prevent the complication. So we are done with this also. Now moving on to the posterior pituitary syndromes. Before that, let's just see where the posterior pituitary is. So here you are having the anterior pituitary, and over here I am able to see the posterior pituitary. Over here with the green you are able to see, right? We are having the posterior pituitary. So posterior pituitary is also called as your neurohypophysis. It is also called as your neurohypophysis, and it stores and releases hormones. The hormones. If I talk about the anatomy, you have the components. What are the components? You have the pars tuberalis, intermedia, and distalis. Okay. Then in the posterior pituitary, you have two parts, infundibulum and pars nervosa. If I talk about the histology, then they contains the pituitary These are nothing but the glial-like cells, and you have unmyelinated nerve fibers and your hairing bodies. You are able to differentiate very well the anterior portion and your posterior portion. If I talk about the hormones, then the hormones that you have is your antidiuretic hormones, oxytocin. They are both synthesized in the hypothalamic nuclei and they are stored in the posterior pituitary. So you have the ADH, then you have the ADH and oxytocin. If I talk about the regulation, then ADH is released and controlled by the plasma osmolarity and blood volume. Oxytocin is by the neural reflexes from your nipples and the uterus that you very well know in your physiology lectures. If I talk about the posterior pituitary syndromes, diabetes insipidus is there, that is due to the ADH deficiency. SIADH, then you have the oxytocin disorders which are rare. Let's talk about the diabetes insipidus. So they are basically due to the inability to concentrate urine due to ADH deficiency. There is antidiuretic hormone deficiency which is there. This figure, the person is drinking a lot of water, but what is happening? My ADH hormone is not sufficient. My ADH hormone is not able to produce the urine. So what will happen? I am not able to, my mind is not getting that signals that I need to excrete the urine out, right? If I talk about the types, then in the types there are central one and the nephrogenic one. Now guys, see, the central one is mainly due to the deficiency of ADH secretion, and nephrogenic one is due to the renal insensitivity to ADH. This is the main difference. If I talk about the causes of central one, there can be head injury, there can be tumors which just suppresses my tumor gland, there can be infection, there can be genetic predisposition, and the cause can be idiopathic as well. If I talk about the central diabetes pathogenesis, there is loss of ADH, there is loss of antidiuretic hormones, as a result of which there is decreased water resorption in the collecting ducts, polyuria, dehydration, and hypernatremia. What is hypernatremia? The sodium molecules will be excreted in a large amount. Okay. Polyuria, polydipsia, dehydration, hypernatremia, and nocturia. These are the clinical features. What is happening? There is central diabetes insipidus, as a result of which there is destruction of your pituitary. Okay. Then what is happening? There is decrease in the pituitary, which decreases the release also, as a result of which there is renal resistance, and after that there is decrease in the free water resorption and increase in the soluble free water diuresis. If I talk about the investigations, then you will see that on doing a low urine osmolarity and high plasma osmolarity, there will be positive desmopressin test. Okay, in your medicine lectures you will learn about something called as your desmopressin test. So there the results will be very positive. The treatment will be desmopressin and adequate hydration, and you have to treat the underlying cause. What are the causes of your nephrogenic diabetic insipidus? There can be hereditary cause, chronic renal disease, lithium toxicity, and hyperkalemia. If I talk about the pathogenesis, so what happens is the ADH levels are normal, but renal tubules are unresponsive. They dilute the urine and there is dehydration. Normally, what is happening? The pituitary gland sends a hormones to the kidney to control the urine that is needed. Okay. Now, what is happening in the nephrogenic one? Your brain